I'd like to call the meeting to order and ask our.
Gracias por estar aquí. Vamos a comenzar.
Buenas tardes. Aquellas personas que están en Zoom, vamos a estar interpretando simultáneamente al español, mi colega María y yo. Por favor, vayan al icono que parece un mundo y escojan el idioma de su preferencia, aun cuando sean bilingües. Gracias. Thank you. We're going to be interpreting simultaneously into Spanish, my colleague Maria and I. So please go to the icon that looks like a world and choose your language of preference, even if you're bilingual, so you don't miss any of the information. Thank you.
Thank you very much. All right, James, would you please call the roll? And also Jackie, if we have any members with emergency or just cause, would you please let us know? Go ahead, James.
Okay.
Thank you.
Soledad, Berto. Soledad. Absent. Nancy Borcher.
Present.
Jane Brooking. Jane Brooking. Absent. Kevin Clarisi. Absent. James Espinoza, present, District 4, veteran representative appointed by Janice Parkin. And on the prevention committee. Genevieve Flores Harrell. Genevieve's not here. Cheryl Heitman.
Here.
CJ Keaveney, I've been told she's gonna be late,
Yes, yes, she's gonna be late.
not present at this time, but I will. Matt Levere, elections. Nomi Marufo,
She's absent.
absent. Diane McKay,
Here.
Jennifer Morrison,
Absent.
Sean Pusey. Here. Dahlia Rodkin,
Here.
Michael Rodriguez is not here. Elizabeth Stone,
Present, just cause.
Absent.
Marlene Torres,
Absent. Oh, yes. You know that President has COVID. Yes. So that's an excuse. No, no. Oh, he's not. Recall. Yeah. Okay, you can call me. I'm sorry, I got distracted. Go ahead.
okay, so we're at Krista Ada is absent, Marlene Torres is absent, Liz Warren,
Present, just cause, so I'm attending via Zoom. I represent Supervisor Lopez in District 5. I'm the Executive Director of the Client Network. I'm a mental health consumer advocate, and I sit on the Prevention Committee. Thank you.
Present, I'm in Supervisor Glowell's district, and I'm the chair of the Prevention Committee. We do not have a quorum. And we are awaiting one or two members, which would, if they are able to attend, we would have a quorum. So With that, I'm going to proceed with the meeting, but we will not be able to approve any action items. We will have to wait and see. Just one moment, please. Okay, thank you everyone for your patience. All right, I wanted to mention that we had on the agenda, we have recognition award for HCA Director Barry Zimmerman. And he is at the Board of Supervisors meeting today, so we are going to postpone his recognition award and we will be in contact with him and have his recognition award at some time in the future. Next on the agenda are chair announcements. I wanted to thank everyone, all the BHAB members for electing me to be your chair and your facilitator for this past year. It's been an honor and my greatest pleasure to serve you this year and for years prior when I was chair or an officer. We've accomplished a great deal for advocating for persons with mental illness and substance use. And I know that with our two executive committee members and the members that we have on this board, that we will continue to do great things for the community at large. And I just appreciate you all. So thank you. Okay, next on the agenda, we have the director's report and Cheryl Fox is stepping in for Dr. Dinnering today. Go ahead, Cheryl.
Janice, I'm sorry, we had public comments.
Oh, did I miss that? Oh, I'm sorry. Okay. Thank you, Jackie, for calling my attention to that. We've had a lot of discussions with county council this morning, so that's causing cause our delays. Okay. She's giving us some great advice because this is unprecedented that we have not ever had, that we've not had a quorum during a general meeting. So I appreciate your patience. All right, and also Mr. LaFollette's patient. So I'm going to be reading a letter from Mr. LaFollette, and it is as follows. At the Cal Voices policy meeting update in May, their lawyer, Esquire, relayed that CSS will be reduced from 76% to 17%, and that Sacramento is acting quickly on a local level in kind, and that there needs quick action to save reduced costs in the contracts. The need for local board of supervisors, Ventura County Behavioral Health, and the mental health boards vigilance, advocacy, engagement. As you know, California's changing policymakers are not yet sure of implementation with no facilities in place. And I think he's referring to Prompt 1 paragraph. Best statewide advocacy response is engage with the California Association of Local Boards and Commissions, who will be exercising broad latitude over programming changes. So thank you, Mr. LaFollette, for that. All right, now, Ms. Fox, would you like to proceed with the director's report, please?
No, I'm sorry.
Oh, I'm sorry. There is a public comment behind us in the room. So please go ahead and see the. Thank you. No, public comments are extremely important. We want to hear from our community. So go ahead, Cece.
Good afternoon, board. At 51 years of age, our loved one has spent the last several days in the ICU. This past year, I have requested that our son receive more intensive treatment and placement at CASA E in an unlocked long-term licensed skilled nursing facility, MHRC, as it was in 2004, 2005. There is 0.25% of clients that require a higher level of care. That statistics have remained a constant and continues to be a gap in the continuum of care. Some neurobiological disorders are treated with a cocktail of antipsychotic medications and require close monitoring, as some interactions can bring about severe adverse reactions. Along with other medical conditions, licensing such as an MHRC has evidence-based intensive treatment and oversight and accountability that is effective and is beneficial as it is in close proximity to our family. Thank you. Please send our family well wishes.
Thank you, Cece. Appreciate your comment as always. Okay, now, are there any other public comments in the room or online? All right, seeing none, go ahead, Ms. Fox.
Janice, I'm sorry, up next week, it says we have the presentation, are we going to be skipping that?
No. Oh, all right, my agenda
Sorry,
doesn't have it. Okay, hold on. All right, we did move that up. Okay, I apologize. All right, next we have our time certain presentation about for Ventura County Healthcare Agency Behavioral Health Continuum of Care Needs Assessment Services Data Presentation. And we have Alex Aguirre, and she is the project consultant. So go ahead, Alex.
Hey there, everyone. Thank you so much for giving us the time to present this information with you all. I also want to give my appreciation to VCBH for providing the data for us to analyze and to take a look at, particularly QI that have been really helpful with us to make sure we're getting everything that we need. So thank you very much for that. I will go ahead and share my screen to go ahead and start. Let me make sure I can't share my screen. Yes, I can. All right, a very long title for not as long of a presentation for the information that we're sharing. But we are looking at the services data, so administrative data. Data was provided, as I mentioned, by the quality improvement from VCBH using their health record system, Avatar. This data is administrative and it's recording requests for service, service usage, and demographics.
Excuse me, if you could please speak a little louder and slow down, please.
Sure.
Thank you. Or closer to the mic, that'd be great, thank you.
Sure. Sorry, I have my AirPods in. Is this level better?
Yes.
Okay,
Yes.
great.
Thank you.
All right. I'll go ahead and repeat what I had mentioned. That its data was provided by Quality Improvement from VCBH through the record system Avatar. It includes administrative data for recording requests, services, request of services, surface usage, as well as demographics. So we begin with looking at care coordination and pre-admission information. So this data represents the number of times the service was provided. It's not necessarily the number of clients that receive the service, so just keep that in mind. There can be repeat users, so the counts are the service, not the client. It should be noted that this administrative data source was retired in mid-2022. So moving forward, this might look a little differently in how it's collected and how it's recorded. Pre-admit enrollments were historically used to support individuals as they entered services. So this prevention and outreach level of care was really helpful to be able to assess where a client was and what kind of services they might need, and to keep them connected so that they have that connection while they're waiting for services should a service not be available to them at that time. as well as assessment and intake when we're really evaluating excuse me, the service that is required, and being able to access community partners and other types of resources that are available to those that request services. For here, we have our clinical treatment programs. This again is the number of the times the service was provided. There can be repeat users, and the counts are service usage, not of clients. We have, again, the prevention and outreach all the way down to something more like inpatient psychiatric unit. Then we have a wellness center that they access services through the wellness center, or outpatient services, residential, and crisis. And we see here that there are quite a few people that are accessing some of these inpatient psychiatric unit services. But again, it's not units, or sorry, it's not individuals, it's the time the service is being requested. Elizabeth Stone, you have a question?
Yeah, I'm curious where some of these services are located and what you're calling them, and in which staff. Is it VCBH staff is providing it, or they're being billed by community providers, or, and that's a long question, so you don't have to answer now, but perhaps later you could, you know, send some information with a little more details about who's providing these services and where.
Sure, I'm happy to do that. I'll take note of that to see if we can get down a little bit more to the nitty-gritty of who are the service providers here. That might not be data that is all accessible to us through the administrative data portal, but that could be something in the future that we figure out a way to make sure that we collect that information and report that information.
Thank you.
Yeah, thank you for asking.
And just ask that if we have any questions, please raise your hand and you'll be called on. But if Alex could finish your report and just save your questions for after we do have time allotted for Q&A. Yeah. Thank you so much.
She has sped up again. I'm a fast talker. I totally empathize, but she's got to keep speaking slowly. I don't hear her.
Okay. I'm sorry. We're also having a little bit of problem hearing you, Alex. If you could slow down, please, for the interpreters, if you don't mind, and speak up a little bit. Thank you.
Of course, and you know, we have an issue with this. I don't really know why suddenly this graph is not available to you, or available to you in a different language. So I'll go ahead and make sure that this slide gets shared at a different point. But I can just kind of go over it. You won't be able to see the numbers exactly since I don't have them memorized, but perhaps somebody on the eval core team that's on the call can provide a little bit more context on that too. The definitions of all of these terms were essentially the types of disorders that clients are receiving mental health services for. So things like mood disorders, anxiety and other types of disorders related to that. And kind of going down the list to something that's more severe, and all of these terms and definitions were based on DSM categories, so not something that we defined. One of them that was in there was factors influencing health status, and that's kind of down towards the bottom of this graph. And those things could be like housing, employment, or food insecurity. So I really do apologize for why that didn't show up properly. But like I said, we will definitely make sure that you have access to that. Here we have the mental health enrollment demographics. So enrollment this does specifically detail for clients and not necessarily for service usage. And we break it down by gender as well as different age groups. And I'm part of the team that works a lot with the community members doing listening sessions and focus groups. And so I'd like to bring a little background to this as well, that things that we've learned from the community meetings, that we tend to believe, or the community at least has voiced, that women are oftentimes more open to seeking and using services, especially in certain cultures where stigma is strong, particularly for male populations. But here we can see that the administrative data doesn't necessarily show too much of a discrepancy between female and male usage of mental health enrollment. So that's something, you know, positive to hear, that males feel that they're able to access and are enrolled in services and not at a huge discrepancy. So our perception is maybe not as accurate as what the data actually shows. In looking at the age groups, we have, excuse me, youth and TAE that are those, they're distinguished between of the ages 0 to 17, transitional aged youth 18 to 25, and then we have a big share of adults as well. And again, from my experiences in the listening sessions that we've been able to conduct, parents and participants in the focus groups and listening sessions noted how difficult it was becoming to seek services or identify services for that transitional aged youth group, that more and more they're seeing a need there. So it's not just adults or youth that may be able to access these services through the school program, through school programming and receive diagnoses at that point too. That age group that, you know, are technically adults now, but maybe not as able to advocate or seek out sources is getting larger. Parents noting that they have trouble also seeking enrollment or services for that age group. And also the youth that are being diagnosed at school or being enrolled rather at schools highlight that schools are a very good resource for distributing information on mental health resources and connecting parents and children to these services. They noted that they really did appreciate being able to access them at school versus needing to find different locations and how to get to all these different locations. And here we have a breakdown based on ethnicity and race. So this one's an interesting breakdown here because I want to note that the other race in the race section, when we did a cross tabs or cross reference with those marked in ethnicity, a great majority of those marked in other race were marked as ethnicity Latino or Latina. I mention that because that certainly makes us look a little bit more heavily at the enrollments for ethnicity rather than strictly just enrollments based on race. And it also suggests that perhaps the user is having some challenges, or maybe it's not defined well enough of where to indicate their race and what it means for them to indicate a specific race. And so we look at the ethnicity section, or the ethnicity cross section of Latinos, and that, you know, they have nearly half of the enrollments. And this doesn't indicate number of services they receive or they seek out. It's purely enrollments. So that's something that we were in conversation within our team of maybe perhaps in the future being able to break down this data in a different way to show you service usage in different ways. It also allows us to probe deeply or more deeply with qualitative research in our listening sessions and our focus groups to suss out a little bit more about service usage, not just service enrollments. And then for additional services that we noted here that we received administrative data for, particularly around the crisis and referral line. A lot of calls were received, around 80,000 to the crisis and referral line. That's a 24-hour line, 24/7 operated line, staffed by people that are both trained and clinical and non-clinical staff to be able to dispatch the mobile crisis team. And the mobile crisis team served nearly 7,000 unique individuals who were experiencing some kind of crisis. And they were dispatched to around 9,000 crisis events. And during the same 4-year period that we're recording from 2019 to 2022, VCBH also received and responded to 26,000, around 26,000 individuals requesting information services when they called the crisis and referral line. So indicating to us that both the crisis aspect of of the line is being used, as well as the referral, that receiving information about where they might go should they need help, even if it's not necessarily a crisis episode. Secondly, we have our substance use services. And again, this is from the same data source of our administrative data. So we have here broken down a little bit differently than the mental health services. We include here level of care, the care coordination and pre-admission section. Before it was in two separate slides. So here I want to just call attention to the care coordination and pre-admission services provided, around 11,000. And the next slide that I'll show you aligns with services with unique enrollments, which then they kind of mirror each other. So those unique services are around 11,000 as well, noting that both services and enrollments are around the same amount of the same number. And we also have here the withdrawal management programs, residential programs, outpatient programs, and narcotic treatment programs, totaling around 32,000 service uses. And like I mentioned here, if you look at the N here of just about 12,000 and the N over here for services provided, they're pretty fairly matched there. For unique enrollments and clinical treatment programs, as you can see here, alcohol-related disorders are at 30%, as well as other stimulants, also including or separating opioid-related disorders, and all the way down to looking at sedative or hypnotic or anxiolytic-related disorders or cocaine-related disorders. When I was looking at this, I kind of also thought about the different type of need an individual would have if they were using substance, if they had substance use disorders or challenges. It seemed that obviously fentanyl has become much more popular in the news as well, and just in everyday life. And so looking at that opioid related disorder over this time period of 2019 to 2022, and thinking about how that might be impacted as well in the future data, administrative data that we find. Around 9,000 unique clients, or sorry, around just under 8,000 unique clients were served in one or more of these services. So as I mentioned before, there's a difference between the unique clients and the number of services provided to each unique client. It makes sense for a care coordination and pre-admission to be a bit higher, and then as maybe people choose not to seek services or not to enroll in services, you might see that number kind of dwindle down. Here as well, we broke it down by gender and age group. I do want to highlight here as well things that we learned from the community and how we matched that up with this administrative data to tell a bigger picture. That between male and female enrollment, and the males by far were enrolling in substance use services at a much higher rate than females. And that was something that was echoed in our community work, where we saw females admitting that, you know, they had a lot of male family members that they were seeking assistance for. As well here, when we look at age groups, we see here that the majority of service usage or enrollment is for adults between 26 and 64. Again, from the community members expressing that services for youth and for transitional age youth were sometimes difficult to find, and that might be reflected in the number of enrollments that we see here. That if they're not able to find, obviously they're not able to enroll. But again, there may be other reasons for less enrollment in those age groups, even if we do see a community expressing the need for more of those services. Here as well with the demographics of race and ethnicity, I do want to note again that we have the same cross-referencing of when we look at other race, that the majority of those indicated in other race are cross-referenced for ethnicity Latino. So if you look at the ethnicity, that shows us a little bit of a different picture, a more specific picture related to program services. There are also additional services and surface usage. This access line and care coordination team. So that would be a lot more of that quick care coordination services that I mentioned in the beginning, about 33,000 calls received there. Individual calls that might be repeat callers or somebody that receives multiple services at the time of the call. BCBH served 4,400 unique individuals via nearly 6,200 unique requests for substance use services. So again, those numbers aren't always going to match up because a unique individual could receive other services or make multiple calls. So thank you so much. I hope that I was able to slow down just a bit for you all, and I'm happy to go over any questions and invite you all to engage with the data.
Okay, thank you, Alex, very much. I know that we do have some questions. I also have a couple, so who would like to go first? Go ahead, Cheryl. Cheryl Hyman. Thank you. So I'm kind of confused, and hopefully you can help me with this. I'm seeing that you're presenting this data and you got it, as I thought I understood you say, from BHAB, from the Behavioral Health Department. Is that correct? Is that where all this came from?
Yes.
You're not up there. We're only saying thank you. Can we get your face back?
Oh,
So
sorry.
We're not talking to an empty, okay, thank you. So.
Yeah,
so
sorry about that. Let me stop sharing so you can see my face.
So you got this information from the department itself here. And is this any different than what they could have just given us? Why is this coming through you as opposed to just getting it from the department?
Like I mentioned, that there are some things that we can ask further questions about. I find that oftentimes when people are surrounded by the data, they might miss some things, maybe not ask certain questions because they've seen it so often. So looking at that crosstabs in particular, of looking at it and seeing, okay, well, here's what the racial breakdown is, but not making the connection to also cross-reference with ethnicity to see how it breaks down with Latinos. Additionally, looking at service usage. That's not something that we have reported on just yet, but service usage by specific race or specific ethnicity, that hasn't been shared before. And so that's something when we looked at the data, it stood out to us to potentially look at those, look at that data since it's available to us, to be able to look at that and really start looking at, well, where this service usage is being put, or where people are receiving the services, what types of services they are receiving, especially coupled with the data that we collect in the community and some of the comments that we have heard about not being able to seek or not being able to find certain types of services. So trying to figure out what the disconnect is there.
Okay, so we're gonna see that in a future report in more detail. Is that what you're saying? This is just sort of a back.
Yes, I'm hoping that that's something that we can pull together in the future whenever we're able to get more data, and also whenever we come back to you all. Because I think there's a schedule for when we report certain items to you all.
Okay, so if I could just go back to the very beginning, and maybe this is anyway, I'm gonna ask this question. I probably should already know this, but what exactly is the scope of your work? What are you supposed to be doing to present to us?
Yeah, my understanding that it's a pretty comprehensive scope. The details of it, I think Kristen, Dr. Donovan would be better to be able to describe the specifics of our scope. If she's still on the call, I'm happy to have her chime in. If not, I can make sure to keep that as something to report back.
I think she's there.
Yes, it wouldn't let me unmute, but I'm unmuted. Our scope of work is available. It is part of, I think it's part of public record. It's to do a comprehensive behavioral health needs assessment of the continuum of care.
Right, so, okay, and you're how far along, and I mean, you've been coming back, I know on a fairly regular basis, how far along are you in that process, and when would we be expected to see a draft of your final report?
So we just finished data collection, and the report will be complete by the end of calendar year 24. And we'll be doing a community-wide presentation of the high-level findings late this year.
And will this board, as the board that kind of got this all started, I think, are we gonna see a draft of that before it's presented so that we can make comments on it?
That is a question for VCB, or sorry, that's a question for the healthcare agency. I'm sorry, I can't answer that. That's really the healthcare agency is the persons to ask that question.
Okay, so, okay, then I'll stop asking because I know I'm asking a lot of questions, but, okay, so you have the data now, you've done some focus groups, it sounds like. And you plan to have this report sometime later this calendar year.
Yes.
Before, okay. And so it sounds, so will, okay, let me just ask this question first. So will there be recommendations of, once you identify where the gaps are, will you be making recommendations specifically about how to fill those gaps, or how, I know you can't make them to actually do it, but how you would recommend these gaps be filled? Is that part of the scope?
We will be making recommendations, and some of them may be that the gap gets looked into further. We're not tasked with telling the county per se how to fill voids. Our role was to assess needs at the big picture, but yes, the report will definitely be including recommendations where we've identified gaps in the system. But I can't say that there'll be us telling the county how to do the filling, if that makes sense.
No, it makes sense. I guess my question was more, we are gonna say these are the gaps that we've identified in your services, and I assume it's gonna be in much more detail than what we're seeing here. And in terms of the recommendations, you've probably worked with a lot of other counties or some other counties, or you've read a lot of reports on them, and just seeing kind of what some other counties have done to fill these gaps, to kind of let our county know what some of the possibilities might be. I know you can't tell them how to do their job, but you, in doing your job, you certainly have seen a lot of, so I'm just hoping that that's part of this report.
Yes, I mean, thank you for pointing that out. Yes, we're looking at, I mean, there are gaps in the United States system, period, and there are huge gaps in California. And some of what folks are trying to do, we're looking into all of that, because the gaps that we see in Ventura County, some of them are unique and some of them are absolutely on par with the gaps that we see across the state and beyond. But yes, where appropriate and where we're able to make thoughtful recommendations about what other states or what other counties in our state are doing, we're going to include those in the report.
Okay, just one last follow-up. I'm sorry,
Yep.
Janice. So in that report, then, when you're looking at the gaps, and you said some of what you're seeing in our county is unique, and can you identify, when you do the report, those as well as the general, but kind of identifying, highlighting, maybe is a better way, of what the unique ones are?
Absolutely. The report is the Ventura County Behavioral Health Continuum of Care Needs Assessment. but I just offer that as like, let's say, for example, you know, people waiting to get services. That is not unique to Ventura County, but what our report is focusing on is, well, what is the waiting experience here in Ventura County? So I'm sorry if I misspoke, but yes, the report is absolutely focused on Ventura County.
Thank you.
Okay, next we have Diane, then Liz Warren, then Elizabeth Stone, then Dr. Hayden. So, and I have a couple of questions as well. So go ahead, Diane.
When I spoke to you, and I believe I spoke to Kristen about a year or so ago, and then we had a private Zoom, we kind of really drilled down on where in the county, and yet nowhere in this report does it say by zip code. I mean, I read this report that we have Latino and non-Latino people, and we don't know where they live, and we know what gender they are, but we don't know what area of the county they come from. We don't, I mean, it's so broad. I feel like this is actually less information than we got a year ago, not more. And I'm just really curious, you know, why we didn't count others between just white and Latino. And I know you said you counted ethnicity, but we don't know about the Black population. We don't know about what Thousand Oaks looks like versus Simi Valley. We don't know about college students versus non-college students. I mean, I just feel like this is so incredibly broad that it's almost like anyone could look it up. And we've waited a year.
All right, thank you,
We-
Diane.
Well, thank you for your question. And this, what we should have opened with was, we are permitted 20 minutes for an update. And we've been doing updates on the different aspects of the data that we're collecting or looking at. And so this is just one snapshot of the analysis that we conducted. When the report is complete, there will be probably 50 pages of the analyses that we did on these data. So when the report comes out, the crosstabs and all the statistics that we ran will be in the report. Today was a quick update on some information, and I apologize if it wasn't useful.
So the data that we'll receive at the end of this calendar year will be disaggregated. We could look at how many non-white females in 91360 zip code needed services and couldn't get them.
No, with the zip code level analysis will not be in the final report.
What about cities?
We'll have to see if it's statistically warranted. There has to be a sufficient number of cases in order to do that. But we have done regional level analyses, East versus West.
Supervisor areas, because that's kind of divided by population.
No.
Okay.
Okay, Liz Warren, go ahead.
Thank you. Thanks, Alex. I appreciate the time you took to come and be with us. Thanks, Kristen. So I understand where we are in the process because I was part of this RFP process. So I know this was just a small, quick data service update. I know that you'll be breaking stuff down, like Elizabeth mentioned on slide 4 of the clinical treatment program. So we look forward to getting all of that. I would like to definitely see below all those categories. I really want to see how many folks are being served at all those individual places. And I believe that's doable. So I'd like to see that if that's possible. I would recommend that you try to do that. I will say that I'm a little concerned because although we're looking at a 4-year period, this is already data that's about 1.5 to 2 years old. And by the time we get to the point of moving forward with recommendations to the HCA and the BOS, that we're going to be working with very outdated data. And I know you don't necessarily have control over that, but is that something that you are you are mindful of, which I'm sure you are, but that you're trying to manage, because you want a real-time snapshot of what's actually happening in the community. And this 4-year period happened to also include COVID. And so it's kind of a bit of an aberration in terms of regular operating, in terms of treatment services. And so I'm just concerned. And is there anything that we could do, or anything that, I mean, I know that QI is doing heavy lifting, getting you all this data, but is there anything that we can do to make sure that we have the most current data when we get to the actual point of, looking at all the gaps, which we all know where they are, but, fine tuning, looking at recommendations, that we're actually looking at the numbers that genuinely reflect what's currently happening today, which, the 2024 numbers, 2023 numbers, because it's great that we know what happened in 19, 20, 21, 22, but at the end of the day, this is old and data needs to be fresh.
Well, I appreciate that, Liz. And in the report, we're showing the year numbers. So we'll be able to see 2020 versus 22 versus 21. So that we're looking at doing trend analyses so that you can see the year-over-year counts. As far as most recent, that is true what you're saying. There's always a delay in data. We always, as researchers, want to have the most current stats. And right now, these are the most current stats. There's typically a lag. I will see if there's more recent stats that we could add, but when we were, it's just common in all of the projects that we do that some of the data, the most recent is the 2020 census, and the rest of the numbers are the estimates,
Right.
But I appreciate what you're saying, and let me loop back around with VCBH and see if we can get another pool of more recent and see what's doable.
I appreciate that, Kristen.
Thank
Thanks
you.
so much. Alex, real quick, you mentioned that you're running the focus groups. Are you doing focus groups with the older adult community?
I believe we did do some focus groups that included older adults. And we have tried really hard to make sure that we're getting a diverse group in all of the focus groups that we've done. So personally, I've done a couple of focus groups with Indigenous populations. We've done some youth as well. And when I say youth specifically, I mean like that transitional age youth, and maybe even some that are a little bit older in high school. And obviously we've done some farm workers, we've done a lot of different diversity. So we have definitely addressed when you say elder groups, and in addition to many others.
Okay, so I'm specifically talking about 64 and over, older adults.
I'm trying to recall if there was one focus group that was specific for them versus some of them being referenced in other ways, other demographics. Because, sorry, Kristen, go ahead.
Oh, sorry, Alex. We interviewed the executive director. We did interviews, Liz, with folks that are with, AAA and representing older adults. I don't believe we convened an older adult focus group, but there was a wide range of ages in our focus groups. We also collected close to 900 surveys of persons who provide services directly or indirectly. We have a wide range of ages in which those agencies serve. We also had, hundreds and hundreds of surveys of the community come in, and we've presented that in the past. And unfortunately, I can't remember the percentage off the top of my head of our survey respondents that are older adults, but we really tried to pull diverse representation in different methods to reflect our continuum of care and the age groups.
Right. Well, my concern is, and I'm sure you share this, Kristen, is that, the aging, we're in this silver tsunami. The entire country is retiring at a rate that's just, it's astronomical, right? So everyone's getting older, and we focus rightly so on, you know, youth, adults, but the thing that I'm concerned about is I want to make sure the continuum of care is properly addressing our aging client population. And I also want to make sure that we have accurate numbers. When I saw the breakdown, it was only 7% of older adults. That to me seems small. I know there's attrition for various reasons, but I think that I'm concerned about that a little bit. And if you haven't done a focus group where you actually have come out here and talked to older adult clients, I think that's something that you should be doing, because they have unique needs, everything from just access to services, in-home support services, and all the wraparound services that they need in order to continue to live independently. And so there's a lot of different things there that I think we might want to, if you want to follow up and you think that's something that you want to do, maybe I could work with making that happen for you, or we can make that happen.
Okay, yeah, thank you, Liz.
Sure.
I'll
Thank
reach
you.
out. Thank you.
Thanks. Okay, thanks, ladies, thanks.
Thank you.
All right, thank you, Liz. All right, we're going to go to, I see, Elizabeth Stone.
Seeing,
Yeah, okay, all right, Dr. Hayden, go ahead.
I believe Elizabeth Stone had her hand above prior, and it looks like she's maybe having some trouble with muting.
No,
Okay, go.
we're blocked from unmuting, so I was being blocked.
Oh, okay.
Thank you for recognizing that. So now I'm even more frustrated. And I'm pretty blunt, so I'm extremely frustrated with this report, and I'm really glad to hear the 3 previous speakers mentioning some of my concerns. The comment that we might be surprised about the way people are identifying their ethnicity or race is perhaps naive about the information that this body receives and is aware of. So I'm extremely concerned on a number of things. It's crucial, as has been mentioned, that we have this cross-sectional data. One hopes, or I hope, and I'm constantly frustrated about this, that we're getting data to improve services. It's not, we don't really keep needing to know what people are billing for, because I'm guessing you're getting billed services, which is partly why there's a delay, which perhaps is part of the needs assessment, why there's so many challenges with accurate billing in the department, that the data is so constantly delayed. So there's that, like, we don't really know who's where. You alluded, or you mentioned the other factors, which of course are social determinants of health. And we know that somebody's zip code determines how long they live. So the request for information by zip code is extremely pertinent. We also know the American Community Survey is done every year or every other year. So we're not reliant solely on census data every 10 years. And I really want to know some outcomes, like how effective are the services? If you add the data for people receiving mental health, 56% of people are under age 25. So I really hope this is prevention and they don't continue into the services, right? We really, the point of early intervention, and we have like a really good early psychosis program, right? So again, like, where are people getting services? Are they continuing? Are they dropping out? People are billing for outreach. Does that mean they're walking along the boardwalk at the beach, which I've seen, and then saying they're doing outreach because they said hello to somebody? So I just have a lot of concerns. In terms of the comments Liz Warren was making, you know, we know that over 60 can't go into a psychiatric hospital, because like having the distinguishing line at 65 doesn't really accurately match what's happening with services if they need inpatient psychiatric care, because they have to go to a different kind of facility, right? So there's just a number of things. So I'm really concerned about outcomes. I'm concerned about lack of specificity. And also I'm hoping and I'm guessing, I will assume optimistically, you're aware of how grossly, meaning largely, services are changing. And so to look at services that were provided or needs that existed previously with the mandates that are coming down from the state about where services are coming, the intersection of people being unhoused, especially among seniors, that's the largest group of people becoming unhoused in Ventura County. It would be really helpful, I believe, if you, instead of kind of doing how all our studies are, is you really looked at what's happening in California, what the department is going to be expected to produce, and how that's happening in terms of what the needs you're seeing that aren't being addressed. So thank you for letting me share that.
Thanks,
Sure,
Elizabeth.
thank you.
Thank you, Elizabeth.
Thank you so much.
Oh, hold on. Did you want to answer that, Kristen, or do you want to wait till the final question?
I think we can move, we're taking notes. I appreciate what Elizabeth shared.
Right, okay, I think, right, and Elizabeth and everyone, if you don't have your questions answered, because we do have to stop the Q&A portion, after Dr. Hayden, please email, Kristen or Alex, and they will provide their contact information at the end of this Q&A, or also, I can also forward it to them. So go ahead, Dr. Hayden.
Hi, thank you for all your work. I may be looking at outdated information, but I'm looking at the RFP, and it describes the continuum of care as inclusive of services provided outside VCBH. And to date, I only think we've seen VCBH. So I'm wondering where the data are for like our local communities emergency rooms or jail data. I mean, those represent the needs, I think, and just seeing what VCBH currently does or has done, I think completely misses the mark of the intent of this needs assessment.
So in the needs assessment RFP, it spoke about that even though VCBH provides 70% or funds 70% of the continuum of care, they wanted an agency to look at the spectrum. Where we looked at the spectrum, including Veterans Court and probation, the schools, persons who have lost loved ones to an overdose, and really went outside of VCBH was, we presented on that last year, and you may not have been privy to those presentations. Again, all of the collected data will be in our report. So the data we showed today was specifically from VCBH, because that's where 70% of persons are served through an agency that VCBH either directly staffs or funds. So the utilization data, you're right, were specific to VCBH. The needs assessment had multiple methods, and this was just a little snapshot that we thought could be useful at a high level of who's using services, mental health versus substance use at an aggregate level. But there will be breakdowns in the final needs assessment report, and all of the interviews and the 900 surveys that we got outside of VCBH about the recommendations, the gaps, where things are, all those data will be included in our final report. And I think, this sharing what we shared today, without realizing that this is an ongoing project and we're doing little snapshots of some findings, I think that may have led to more confusion, because there were 3 or 4 presentations last year on data collected from the community and persons outside of VCBH. I apologize.
So you know how many, for example, people enter our emergency rooms last year on a psych hold or evaluation for a psych hold. You have those data.
The data that we have is everything that funnels through VCBH for the extant trend statistical utilization data. That is where we were told to focus for the raw data files that we analyzed. the raw data.
Okay, so you don't have those data. I mean, you don't know how many are in jail or
We have compiled statistics on those numbers, but we didn't analyze those data. We pulled those data. Does that make sense? Today was data that we actually analyzed and broke down and put them into the continuum of care levels and race, ethnicity, and age. But if you're asking, will we be able to report on persons served, for example, through mental health services at VCSO's jail? Yes. Those data will be in the report.
Okay, and I think as Elizabeth was saying, given we have SB 43 coming on board on the near horizon, relatively near horizon, you're going to be able to project how many, for example, in our homeless population fit the criteria for SB 43, and we're going to need this many more inpatient beds and this many more supported living beds.
Oh, go ahead. I thought somebody was saying something. We're doing projections. We will not be able to do everything with the level of specificity that everyone is seeking. And one of the components of the report is around Prop 1 and what is known by counties at the time of writing the report, and what the state is still navigating at a state level for the implications and the changes that are going to be coming down for the different state assembly bills. Prop 1, had we written this report 8 years ago, 5 years ago, there was, as you know, a lot less changes in legislation. I think our report at best will be able to share gaps, needs, recommendations in a particular point in time at which this project went out to bid and was conducted. But you're spot on. The information will continue to unfold from the state of California across every county, and the counties are still trying to figure out how all of this will be navigated. You're spot on.
Okay, thank you everyone for your participation. Please email either Kristen or Alex. Do you have your contact information up there on the screen, or can you put it up? Or do you want to just verbally say it? Because we have to close this portion now. Thank you very much.
I'll put it in the chat.
Okay, well, you can just send it to, you can send me the information.
I'll send it to Janice. I'll send it to you because the chat says it's disabled. Let me go ahead and send it to you to send out.
Okay, thank you very much. Thank you, Alex. Thank you, Kristen, and thank you everyone for your participation on this agenda item. Okay, next we have, okay, I'm deferring my chair comments. I wanted to let everyone know that we will be deferring any of the, not only the action items, but some of the other items that are on the agenda. But we do want to hear the director's report from Cheryl Fox, who is the Youth and Family Services Division Chief, and she will be reporting on behalf of Dr. Dennering, our intern director, BCBH intern director.
Okay, good afternoon, everybody. That was a whole lot of saying my name 3 times for me to say. I just want to refer you to the director's report in the packet for your review. And if there's any follow-up questions you might have, you can reach out to our BHAB aficionado there, Jackie, and look into any of those additional questions you might have. And that's all I have.
All right, are there any questions? All right.
Yes.
Any, okay, go ahead, Nancy, and then Elizabeth, go ahead.
I'm curious if you could explain a little bit about the DUI services being transferred to the AERS. it's a quote, I don't recall what that stands for, but I'm wondering, why is the county dropping during that program and assigning it to someone else?
I think we would need to defer that to DUI, but I know it's been part of the ongoing discussion and presentations. And the Alcohol Education and Recovery Services is the AERS.
All right, Elizabeth, go ahead.
Just Nancy, they told us when they put out the RFP on that, it was for financial reasons, that it was a fiscal decision. But my question is, it looks like there's a closed session with the Board of Supervisors today to appoint a director of VCBH. And I'm wondering who on the BHAB sat in on the interviews for those candidates?
BHAB members sat on the board, on the panel. I was one of them. I'm not at liberty to disclose any other information. We were asked not to say who was on the panel or how many BHAB members were on the panel, but the BHAB was represented and always is through our bylaws that we have at least one person from the advisory board on the panel.
Right, and that's public information because it's a public law. So the fact that once again, the county is trying to be very opaque about political decisions is concerning to me.
All right, well, that would be something, if the county would like to disclose who was on the panel. Is that your question? Who was on the panel? Then that would be up to them. I think it's an HR concern. So, thank you. All right. All right, since we cannot discuss any of the action items, I am going to present the prevention committee report. Kevin is not here for the youth and family, and as I mentioned, we're going to defer any agenda items that we did not get to today. Due to the fact that we still, even though we have more members that have joined us, like CJ, we still do not have a quorum. So I'm going to proceed with the prevention committee report.
Could we, I'm sorry, James, but were we not able to get a hold of Chris? I mean, if he could, he's sick, he could do just cause, could he come on at least so we could do the vote, some votes and maybe at least clear off the election items and start fresh?
I texted Chris, he's not gonna.
He's sick. Did you know? Yeah, I'm sorry, we now have 1, 2, 3, 4, all right, 6, 7, 8, 8 board members plus Elizabeth and Liz. There's 10, and we have to have 11. Yeah, we're missing one board member. Okay. All right, Ashley Nettles, who is the program director of Two Trees Community, gave a presentation about Two Trees Community Outreach Center and expanding overdose prevention data-informed strategies in Ventura County. Two Trees Community Outreach Center is a group of residents and champions in the community, try to go a little slower for our interpreters here, who help confront those who are isolated and feel hopeless due to addiction, barriers to service, generational poverty, and unsafe streets. They provide life-changing hope through connecting unhoused youth, working families, and underserved, marginalized communities to services and programs. Counseling services and after-school programs focus on, among other things, STEM, vocational skills, and other needs. Overdose institutional training since Two Trees came on board have added 64 new sites since 2023, including K-12 school districts, community-based organizations, county agency, and county clerk's offices. Two Trees has also provided 28 educational trainings in overdose prevention and has certified 287 overdose educators. They have participated in numerous prescriber trainings for physicians, pharmacies, nurses, and dentists. And I also wanted to mention that VCBH won an Astor Award for the Speaking Up on Fentanyl video series. So that's it for the Prevention Committee report. I can ask for board comments of anyone in the room or anyone online that's a board member. Anyone in? Okay. Go ahead, Elizabeth. Go ahead, Elizabeth.
I really just wanted to respond to, I think her name's, Diane, about the quorum. The just cause people can only, there has to be a physical quorum. So even though Liz and I don't know if anybody else is participating by just cause, that does not, count toward a physical quorum to be able to take action. That's
This
all.
is all discussed prior, so, all right. Yes, board member comments. Go ahead, James.
All right, so I just want to kind of go on the record and say that I hope that the folks that are not showing up, if somebody's reaching out, that we can find out their level of commitment, so that those of us that do drive an hour in can be productive. If that's possible, I don't know who has the contact list. But on the veteran end of it, as a veteran representative, I continue to advocate for veterans, actually nationwide. I attended 2 natural events last month and also participated in a VA, a Veterans Administration Public Service announcement video that will come out in September. Just want to say that the advocacy is alive and well through both my nonprofit and my new consulting work. I also advocate for first responders as well. So just wanted to add that in. That's it.
Thank you, James. And I appreciate your comments as always. Did you want to mention the veteran event that's coming up?
Oh, yeah, so we can get in the notes. So there are actually a couple veteran events coming up in July 21st. There's the Ceviche Chow Down at the Olipas Adobe by Mission Fish USA. And then August, I think there's a new event that came up. 13 Souls Run will be doing an event in East County. It's for, they participate, they do this run annually for the 13 Marines that were killed in action in Kabul when we withdrew from Afghanistan. That's a different organization. I'm not associated with them, but that's on August 24th. And then you can look these all up online. And then in September, we're planning a 2-day event where there's a fishing trip on September 13th with Mission Fish USA and a resource event on the 14th. Both of those will be out of the Chow Harbor. So if you know any veterans or first responders or Gold Star family members, that September event is for them.
Okay, thank you very much. Any other comments? Board member comments? All right. Okay, next we have new business, presentation requests. Please send them to myself and Jackie. Recognition award recommendation, same thing. No old business. Are there any comments about the contracts? Okay, go ahead. Nancy Borchert.
I was confused by the, there's a discussion about the Great Bridge, or the grant that of bridge housing that the county was awarded. And it was like $13 million, 325,000, big money. There was mention that there's much of the funding may need to be reallocated, or else it will be taken back by the state. That would have to be given back to the state. And there were some things that were on the books there that for one reason or another didn't happen. And I think there was, I don't even know for sure what they are, but we've talked many times here about the site out on Lewis Road, near the Chandra University. It seems like that's off the table now. I don't really know. Or it certainly isn't 125 units, and on there it's maybe less, or maybe not at all, I don't know. But I'm just wondering, then they did talk about, one of the good things was that there was gonna be 16 new short-term beds at recovery residences, and that's gonna spend $1,456,000. My question is, has the rest of the money been used? Is it going to be used? It needs to be used, how soon? When does that expire? Those are my questions.
I believe, Ms. Fox, you would like, any questions of that detail to be sent to Dr. Denery, is that correct?
I think they can be forwarded to Jackie.
All right,
Just so we make sure to get the accurate information.
okay, thank you.
One more question.
Okay, go ahead, Nancy, finish and then Diane.
Some of the contracts show that, at Casa de Esperanza and at Golden Hillmont House, some of the, there were some needs to increase their funding, actually only until today, or, end of this fiscal year. But it's kind of significant money, but they were saying over and over that SSI was paying less, or they got less reimbursement from SSI. I don't know if that means they have fewer people with SSI, or the rates are suddenly lower than they used to be, or, Hillmont House had some penalties. I don't know what dock increases are. That was a thing that they mentioned. Do we have more people with less money, or there's confusion about SSI usually pays a certain amount and everybody knows what that is, and those housing things were. And they do get a COA almost always, so I don't know, it seems puzzling that some of the asking for increase to these contracts was due to SSI, lack of SSI funding or less. So that would be my question, why is it less? No, everybody's, I mean, if you knew.
Oh, I do not know.
All right, so, Nancy, if you would pass along these questions, and anyone else who has a question, pass it along to Jackie, please CC me, still the chair for another month. Okay, I have, a question from Diane and Elizabeth Stone, and then we'll move on, thank you.
Mine just kind of brought, we get these same contract, we're not the same, different one on during committee meetings. And so what we saw at the Family and Youth and Family Services Committee meetings, since it didn't get reported on today, and it's then now these are different contracts that we look at today. It doesn't make sense to me that we have things for committees to see that may or may not ever get reported on versus things that just BHAB, that this full board sees.
That shouldn't be the case. All the contracts should be on the full BHAB agenda. Jackie, I think Jackie sends out to the committees some of the contracts, but they should all be listed. Every contract that you're seeing on any committee should be listed in our Board of Supervisors contracts for the general meeting. Jackie, can you address that, please?
Yes, every contract that you see it here first at the general meeting, and then the subcommittees are usually a little bit behind the general meeting, so those are the older contracts, and then because they need to be seen by the full BHAB first, and then the subcommittees can discuss them on their own.
Okay, so my question, Diane, would be if you can take a look at when that contract, or maybe
I'll look at the meeting we just had, for example, and see how it compares to what is here.
Okay, thanks. I think she's saying that that might be a previous contract, but they should all be listed during the general meeting. 1 second, Cheryl, I have to get Elizabeth. Okay, go ahead, Cheryl.
Sorry, Elizabeth, just answering. As I remember, I don't know if it was last year or the year before, I think we decided that we were gonna send the contracts that were specific to a committee to the committee and let the committee see them. And then if they wanted to bring something forward to the BHAB, they felt they could. I thought we were trying to cut down these pages, some pages of contracts for all of us to make it more specific. I might be wrong. That's what I remember.
That's exactly what happened in that, and it takes a lot of time and effort for Jackie to do that, and that is what happened. So that's why I'm thinking maybe that contract is an older contract.
Well, what Cheryl said is the committee sees them and then only the ones we have questions about comes to this body.
No, it's the other way around.
What we proposed that. But I don't wanna argue this, but I don't think that's what we voted on. Maybe we could check into this because that would make no sense. If we're gonna send the specific ones like this one maybe was that Diane's talking about to the committee that it most applies to and ask them to review it in more detail, perhaps then it would come here, it would make sense to say, hey, we looked at this and we had a concern or we had a question or whatever. I mean, why would we bother at the committee level then if we've already all seen them as a full board? So.
Okay, I see what you're saying. I misunderstood. I thought that they were coming to, that all the contracts for the general meeting were already reviewed by the committees. Is that not the case, Jackie?
Sounds like opposite. Like,
Let me just
maybe after they're reviewed here, and that doesn't make any sense. Yeah.
No, so they're reviewed by the general meeting first and then the subcommittees.
I think it's just maybe because the committees had some more acute interest or maybe some knowledge about what was going on in different places that might cause you to question. I don't know. It seems like, I mean, clearly, we're not recommending to anybody that they be approved. They've already been approved by the time we see them. So we're just saying, are these numbers making sense to us? And then maybe, again, we need to follow the dollars. That's what it's about. To a large extent, the dollars pay for the services that we hope people get. So we need to pay attention to that. So I do think that it's kind of, even though it's in retrospect, if people who really know about children's services are reading those things, that's more important than me, who doesn't know anything about it. So.
Okay, well,
Janice,
Yeah.
can I just chime in? Because I handle all of the board letters. Every single board letter that goes to the Board of Supervisors is given to the general BHAB to be reviewed during general BHAB. So the contracts that you're looking at today, the Board of Supervisors approved in May. So it's always a month behind.
Okay, Andrea, thank you. And we'll still look.
And yes, I don't know about the subcommittees. I don't know what was talked about that, but it was our understanding that we were to give the executive summary along with, I think there's like a spreadsheet Jackie does. And we bring it to the general meeting every month and it's the previous month's Board of Supervisors.
Thank you, Andrea. Appreciate that information.
You're
Okay,
welcome.
let's Go ahead and then we'll go on and I will close the meeting. Go ahead, Elizabeth.
Okay, I agree. My recollection is that the subcommittees who have some more specialized knowledge see the contracts first, bring them to the general meeting. The other comment, if I recall, Loretta saying last time, as well as hearing from the state, due to the deficit that the bridge funding has been cut. And I kind of made the comment that, oh, they're speeding up Prop 1 money because they cut all the bridge funding. And she kind of, made a, smirk, but that's basically what the governor's done. He's cut the allocation of behavioral health housing to quote, because of the deficit, and theoretically has speeded up the dispersal of Prop 1 funding. So again, I agree with everybody. This is something I said a few years ago, really follow the money because, and Nancy's concerns about, there has been frequent irregularities in some of the reporting around funding from contract agencies. And I just will never forget because it sticks in my head. One agency was not doing their accounting in line with their budget, and it was like $400,000. And so the county was not gonna honor their billing, and the agency sued and got the money. So there's a lot of stuff going on with the money. So I'm really glad to hear you asking those questions, Nancy.
Okay, thank you, Elizabeth. All right, before we close, are there any public comments? See any hands raised? Any public comments from anyone in the room? Right, I just wanted to say how much we appreciate everyone's participation. Regret very much that we did not have a quorum today and we could not get to some extremely important items, action items. And James, thank you for your comments, and also to anyone who traveled a long distance today to attend. And with that, the meeting is adjourned. Thank you.